Okay, good morning, everyone. My name is Sauman Gupta, and I have earned my PhD in cerebral palsy. And I work in Sikkim Manipal Institute of Medical Sciences, Gangtok. And today's session, I would be taking on outcome measures and how to choose the right one.
Saman,
Yes, ma'am.
I can't record. You
No,
have to give
it's
me
okay. I have
permission.
done it. I have done it.
Okay. Okay.
Okay, ma'am. Are you all able to hear me?
Yes, sir. Yes. Go
Okay,
ahead.
fine. Madam's session was on tests and it was on measurement variable. And Madam has nicely told about what kinds of variables are there and how we do the measurements. And you must have heard about, or you must have remembered the kind of measurements you have done in your undergraduate, postgraduate. Some of them can be linear measurements or muscle length or angular measurements like goniometry, or it can be chest expansion, it can be Glasgow coma scale. So you know that there are categorical variables, there are continuous variables, and there are nominal variables, there are ordinal variables. So now I would talk about some of the tests and measures, broadly termed as outcome measures. And I would tell you certain properties of the outcome measures and how would you choose for a particular condition. Okay. Uh, as you all know that physiotherapy is relatively new in rehabilitation medicine relative to the other branches of medicine and health practice. What we need is accountability and professionalism. So the outcome measures which we'll be talking about will give you a sense of understanding of how you could become accountable and how it will be professional to use outcome measures in your uh, daily practice or clinical practice. Now we talk about outcome measures in this session because there is not much awareness of outcome measures and what we should measure, and the history of research in physiotherapy is not quite old, so there may not be much information about when to use these outcome measures. Now in recent decade, emphasis is placed on quality healthcare, that is delivering quality based healthcare. Now, these quality metrics, or you can measure the quality of healthcare by appropriateness of the intervention and the effectiveness. So it's a vicious cycle, that is, to measure the intervention, to measure the efficacy of an intervention, you require outcome measure, and it will give you clear evidence of efficacy. And clear evidence of efficacy gives you information about appropriateness of the intervention. So in short, you are professional, you are ethical to your clinical practice. Now there is an era in last century known as outcomes movement, and it came post World War II, when there were many patients who had come from World War. There were many soldiers wounded, and it was just not possible to provide quality healthcare to all of them, and that's how the cost containment came into the picture. Now we have to preserve quality of care while containing the cost within a limit. There was an era of assessment and accountability. Since they were all soldiers, their improvement had to be told to the government and the people who were paying for it. Again, the insurance system and the medical insurance scheme had come, which put a stress or emphasized on assessment and accountability because somebody else was paying for it. Now, we need a greater consistency in service delivery, and that's how we started evidence based practice or evidence based physiotherapy or evidence based medicine. Again, while recording uh, improvement interventions, guidelines, we need outcome measures, we need some metric which can measure consistency in the service delivery, and that's all can be measured by outcome measures. Now, outcome measure, when we go by dictionary meaning, it just means a visible or a practical result. It also means assessment of a disease or injury severity, or when you want to discriminate two states of a disease. Outcome measures are some kind of health status, broadly talked upon under health status measurement. And health status measurement is a direct measure of some aspect of the health in which improvement is sought, whether or not its relationship to any intervention, social or environmental circumstance is understood. Again, another example which I can tell you without going into the physiotherapy details is infant mortality rate. Everybody understands what is maternal mortality rate and infant mortality rate. You're just trying to find out how many infants get quality medical care and how many mothers get quality medical care while delivery. Outcome measures is a subtype of this health status measurement, and we record the changes in the measures, and the changes in the measure are known to be largely attributable to health service intervention. For example, in the field of pediatrics, if you talk about cystic fibrosis, we want to know what is the life expectancy of a child with cystic fibrosis. So the life expectancy becomes an outcome measure. Again, there is another term known as implied outcome measurement. It is an indirect indicator of health and used as a proxy for an outcome measurement. Example is immunization coverage, coverage of a screening program of proven effectiveness. Mostly in community rehabilitation, community-based rehabilitation, we do not have any objective measure or outcome measure which can directly say that the program was successful. So you can take this example of polio immunization or other immunization programs, and if the number of people who were reached were large, then we can say that the community rehabilitation program or immunization program was successful. It may also be described as a functional status measurement and a quality of life measurement. These measurements can be made without necessarily seeking improvement in the quality of life of people. Now, if you look at this piece of a paragraph which I have taken from a journal article, it talks about what a physiotherapist does to the patient. The physiotherapist completes a full baseline assessment and a set of appropriate outcome measurements. The physiotherapist then reviews the findings and outlines a proposed course of action using the current version of clinical guidelines, which is primarily based on the professional consensus and is appropriate to the clinical findings and the preferences of the patients. At the following appointments, the patient re-evaluates the patient, physiotherapist re-evaluates the patient using standardized outcome measurement instruments, which demonstrate that the patient is improving. This is consistent with the reports of the patient. Now, can you see the circles? Can you see the dotted circles? Can you see the circles with dashes? They all give you an indication of outcome research evaluation. Yes, madam?
I'm still seeing the front first slide only. Slide is not moving.
Oh, okay.
Okay. Okay. Thank
You
you.
know,
Yeah, do full screen.
can you see now?
Okay.
Can you see the paragraph?
Yes, yes, yes.
Okay. Okay, so if you look at the paragraph, I have marked a few circles. I have marked few lines over some words. These words, a full circle suggests we are talking about outcome research, outcome measurements for evaluation of a patient. Now, you apply some kind of a therapy or intervention using some kind of clinical guideline. For example, ultrasound, when should you use 1 megahertz or 3 megahertz? You would decide based on the type of clinical condition and what does the literature, medical literature or a book says. Then you would use evidence to inform intervention. That in lateral epicondylitis, 3 megahertz was successful in reducing pain of the patient and improve the functional status of the patient. Now you would gauge the clinical effectiveness on some kind of an outcome measure, and you would re-measure it on the next appointment. Outcome measures complement traditional clinical measures like physical examination, and according to the authors Kirshner and Gayat, outcome measures can be classified into evaluative, discriminative, or predictive kinds of outcome measures. Now, when we talk about evaluative measures, they document the amount of change in outcomes of interest, which should typically change in a study population or within a person, either due to effects of treatment or in deterioration of outcomes due to the natural history. They measure these measures are valid and they should show longitudinal reliability and sensitivity to change. The reliability which is expected out of an evaluative measure is test retest reliability and responsiveness to change. I would talk about gross motor function measure. It's a capacity measure used in children with cerebral palsy, and it gives you an indication of how good the gross motor functioning of a child is. They are evaluative measures. You can reuse the measure. You can retest the child at specific intervals after you have given them intervention. They show sensitivity to change for cerebral palsy and Down syndrome. They have reliability and minimum 5 points difference on GMFM measure shows that it is responsive to change. That is, if on the next appointment, if you get any reading which is 5 points above the previous reading, you can say that GMFM is responsive or the measure is responsive. Predictive measures, they are the class of outcome measures which classify a person or an individual on an external criterion or target criterion known as predictive measures. They show intertester reliability, and predictive measures are usually used for diagnostic, prognostic, or screening purposes. For example, motor milestones used in pediatrics. They are predictive measures. They tell you what is going to happen. They prognosticate. The another class, in contrast to evaluative measures and predictive measures, we have discriminatory measures. Now, discriminatory measures can be classified. They classify a disease severity. They classify the status. The most common example is Brunstrom stages of grading, or gross motor functional classification system, used to classify severity of gross motor functioning in children with cerebral palsy. Discriminative measures are measures which quantifies difference within a particular category of or group of patients. Um, Example I have spoken about is GMFCS and Brunstrom grading. And discriminative instruments, they are reliable and need not be responsive to change, as they are not required to show changes over time. Now we come to the further classification of outcome measures. There are subtypes of outcome measures known as biomarkers and clinical outcome measures. Now, what do you mean by biomarkers? According to WHO, biomarkers can be anything, or biological markers can be anything, any physiological state which can be measured in the body. It can show whether the cellular structures are normal or they are working properly, or physiological processes which are functioning normally, and usually they are picked up by ultrasound, MRI, evoked potentials, etc. Now if you want to measure clinical functions and you are giving an intervention and you have a certain time point during which you need to see the intervention, and if there is no change in the patient, then you would request for these kind of biomarkers. These biomarkers are mainly used in clinical trials where they have got a certain time point, that is 6 months or 3 months, for testing the intervention. If the intervention is doesn't show improvement, they usually look for these biomarkers, or specifically they look for these biomarkers and then they see the change in the improvement of patient's status. Now, biomarkers give early signal of activity of intervention or therapeutics, and there are some kind of biomarkers which are not specific to the disease or features of a disease, but they are specific to the presumed mechanism of action of intervention. In short, biomarkers can provide an evidence of proof of mechanism. Now, coming to clinical outcome measures, in short, they will tell you how the patient functions. When outcome measure focuses on function relevant to the patient's functional daily activities, the aspect can be captured easily and improvement can be communicated easily. It helps us understand how patient's disability affects the function. That is the main difference between clinical outcome measures and biomarkers. Now, biomarkers have got a certain time point, and in order to gauge intervention, you need to have certain clinical endpoints. Now, when you use biomarkers, they may not have relationship with how the patient is feeling, and how the person is able to perform their activities of daily living. Biomarkers are objective and quantifiable, but they do not correlate with a sense of well-being of patient. Usually, you need to keep a clinical endpoint saying that at the end of 1 week, my intervention should be easily showing change in muscle girth on ultrasound. If you don't see a change in improvement in muscle strength, that is on manual muscle testing or dynamometry, you can also look for clinical biomarkers such as angle of pination, thickness of the muscle on ultrasound. So this is where you can objectively use biomarkers. Um, the use of biomarkers is actually limited in a clinical application because of our profession. Because in India, mostly we work on referral systems, and these biomarkers cost a lot, and therefore we required a medical professional to prescribe for biomarkers. But if the physiotherapist is knowing what to be done, and has got experience in dealing with biomarkers, the physiotherapist can ask for a biomarker study. Now, an old article of last century that is published in 1998, it showed that there are some kind of attitudes in using outcome measures, and it suggests that some people, 52% of the people do not use outcome measures due to lack of time. 82% of people do not use outcome measures because they do not have any knowledge about outcome measures, and 51% because of the unavailability of the outcome measures. 51% do not use outcome measures because it is unavailable to them, or they do not have any they do not have financial ability to buy these outcome measures, which cost thousands of dollars. Now, coming to the broad use of outcome measures, it measures the success of a therapeutic intervention program. It measures the rate of progression or severity of a disease. It can provide normative data. It can provide functional level of the patient. It can assist in development of a problem list. It can predict an outcome. It can be used as a teaching tool. It can be used in communication with other services or other professionals. Now, when we use outcome measures, we should always know that it should be age appropriate, it should be easily administered, it should be functionally meaningful, and it should provide minimal patient burden. Why I speak about age appropriateness is there are many functional status evaluation measures, which measures participation of children, which measures participation of adolescents, which measures participation of adults. A measure which is used in adults cannot be used for children, just because the development of functional status of children is not equal to that of adults. We cannot say that um, children are younger adults. Okay, they should be easily administered. If it causes too much of confusion, if it causes too much of patient burden, if it increases your problems, and the patient does not want to cooperate with you, then probably that outcome measure cannot be used. Somebody has got a question? Somebody has a question? Okay. Now, I want to specifically talk about outcome measures and certain kind of a characteristic, that is when you are measuring different states of severity in the same kind of a disease, that is broad clinical phenotype, mostly used in neuromuscular conditions and conditions which rapidly deteriorate, or chronic conditions where the increase in disability is inevitable. So we should choose an outcome measure which talks about the spectrum of disease severity. We should see the functional ability. We should be able to gauge the functional ability in that spectrum of disease severity, and we should be able to. Hello. we should be able to record a single motor performance. So if I take an example of two neuromuscular diseases of childhood, that is spinal muscular atrophy and Duchenne's muscular dystrophy. Now, both these diseases have wide varieties or phenotypes. That is, SMA can be classified into type 1, type 2, type 3, type 4. Type 3 or type 2 may be more severe than other types of SMA. Again, in Duchenne muscular dystrophy, there may be different stages of a child undergoing dystrophy. So, the time required to perform Gover's maneuver can also be used as an outcome measure or indicator of a therapeutic, or can be an indicator of how a therapeutic drug is acting on the disease severity. So if the child takes a lot of time in performing Gover's maneuver, probably the drug is not acting, in comparison to a child who is being on a drug where the child is able to perform Gover's maneuver quickly. Now, there will be certain state of a disease where the child will not be able to ambulate, or child will not be able to perform Gover's maneuver. Then at that time, Gover's maneuver cannot be an outcome measure. I hope you all are understanding. Similarly, in spinal muscular atrophy, there may be different stages where a child cannot sit independently. There are measures to measure that particular state. There are some children who can sit by support. There are some stages of the disease where the child is able to stand but not able to walk. There are some stages of the disease where the child is able to walk but cannot get up from the floor to standing position. There are some stages of the disease where the child is able to walk but cannot run, jump. So at that particular time, the decision to use an outcome measure should be already given in the inclusion criteria. That is, if the patient's condition is going to deteriorate in your clinical study period or in your daily practice, you should render those outcome measures, or you should use those kind of outcome measures which will give you the information consistently. Not You should not use an outcome measure which will tell you about the walking status, and then it is unable to gauge improvements or unable to gauge the severity during non-ambulatory state. For example, 6-minute walk test. There'll be certain time in both Duchenne's muscular dystrophy and spinal muscular atrophy where 6-minute walk test cannot be used effectively. Now, how to choose an outcome measure? We have to ask why we want to measure the condition. We have to make decision why we want to evaluate the practice. Now, we want to understand what decisions might be made with the information collected. When this outcome measure should be used, we need to determine when to collect the information, admission and discharge, whether we want to measure at the admission, we want to measure at the discharge. There are certain conditions like trauma where there is no pre-trauma evaluation. Now, again, we need to look for the best outcome measure. So we have to search and find the best outcome measure in terms of the measurement properties. And we have to plan when to implement these outcome measures into the clinical practice. And we should know what to do with the results collected. Now when we have large plethora of outcome measures in medical literature, we need to find out whether the outcome measure is really good or not. Therefore, before using outcome measures, we need to evaluate in our own practice whether this outcome measure would provide information to you as you need it or not. Has it been adopted by all who should be using it? Now, there are certain properties related with outcome measures, which is reliability, validity, which has been spoken about, which is already spoken by ma'am. And there are other properties like responsiveness and minimal clinical important difference. Uh, Minimal clinical important difference is the minimal amount of change over which you can say that the patient has improved over a certain condition. Any outcome measure which does not have validity, reliability, intertested reliability, intrasession reliability is not a good measure. Similarly, an outcome measure should be valid and it should be measuring what needs to be measured. For example, if you want to measure gross motor condition in spinal muscular atrophy, cerebral palsy, we can choose the same gross motor functioning measure or the components which is developed for cerebral palsy, but it can be used for um, spinal muscular atrophy, because we are measuring ambulatory changes. We are measuring the transition from lying, sitting to standing or running and jumping. Now I'll talk about the competency in using an outcome measure. The first is knowing enough about test construction to develop own outcome measure. We are not going to develop outcome measure in this course per se, but we would definitely try to ask how what outcome measure consists of, what are the domains the outcome measure consists of, whether it is measuring in a good way. We need to know how the outcome measures would provide information and whether it can be linked with other informations in ICF framework. We want to know whether the scores are comparable to the baseline across the groups. We want to know whether enough measurement properties are there to choose these particular outcome measures. We want to know whether these outcome measures are suitable measures. We should be knowing what to do with these outcome measures. Is it nominal? Is it ordinal or categorical, or it is a continuous measure? Whether statistical tests can be done on these outcome measures. We should know why we want to use the outcome measure. We should know which outcome measure to be used to track clients' progress. We should know how to score the measures, and we should know how to administer outcome measure in a standardized manner. Therefore, outcome measures are also known as standardized outcome measures, just because they measure capacity of a person, and capacity of a person should be tested in a standard environment. This is an ICF framework, and it depicts the fields or the biomarkers or outcome measures which are measured in different domains of ICF framework. If you can see in cerebral palsy, strength, fatigue, endurance, energy expenditure, pain, spasticity all tell you about the body function. So we will choose outcome measures which will measure strength, which will measure fatigue, which will measure endurance, which will measure energy expenditure, which will measure pain and spasticity. When you come to the activity domain, we use functional ambulation, we use bimanual motor activity as an outcome measure. We can use 1 minute walk test, 1 minute run test, 6 minute walk test, etc., or energy expenditure studies. During assessment of participation in cerebral palsy, we would use certain kind of scales or outcome measures which will tell you about the participation status. And overall, when we try to measure a person's condition, we would be using a health status measurement known as quality of life. This ends the session on outcome measures, and I hope you would be able to classify your outcome measures into predictive, evaluative, or discriminative measures. I have developed an assignment for you, and as an assignment, I want to tell you the purpose. I want to tell you the purpose of outcome measures, and I want you to prepare a list of outcome measures in some entity or condition, like mobility functions in Parkinsonism, hand functions in TBI, or hand functions in spinal cord injury, or you can even classify in these three classifications of outcome measures, which can be discussed in the next webinar. Thank you very much.
Give me
Any question?
host. Nobody's there, only I'm there.
Okay.